you?
Good.
All right. So good morning, everyone. Thank you so much for taking the time out of your day to join us this morning. I'm excited for the guest speaker we have today, Lance Lee. So I'm going to do a quick intro for him. But before that, I'm going to do a little bit of housekeeping. This is our education stipend opportunity for March. So this is a way for Alabama Lifespan Respite to say thank you for coming and showing up for yourself, for your care, for your loved one that you're taking care of. And so anyone who participates in the post survey today, which I will send out after the presentation, if you complete that within 24 hours, you will get a check for $25 from us. So the way that you get that survey, please put your email address in the chat box. This is how you will get that survey. And I will say that it has to be filled out within 24 hours, and it can only be one stipend per household, okay? So let me introduce our speaker today. This is Lance Lee, and he has 24 years of healthcare experience serving in geriatric mental health and long-term care. The majority of those years were spent serving in hospice care. So for the last 8 years, Lance has served as community educator at Expect Care Hospice, which is a family-owned, faith-based hospice in the central Alabama area. During his hospice tenure, he has served as chaplain and a volunteer bereavement services manager, and his current role as community educator includes educating caregivers, patients, physicians, social workers, and other healthcare professionals of the benefits of hospice and palliative care, as well as providing direct support to patients and caregivers who decide to transition to hospice care. Lance is an active member of the Alabama Lifespan Respite Coalition and the Chilton County Elder Justice Alliance. And in his spare time, he enjoys spending time with his family and is also in school pursuing his master's degree in social work. So fellow MSW, happy to have him here. And I really appreciate Lance's approach to this information, because I know sometimes we hear the word hospice or palliative care and we can kind of bristle because we think, there might be a little bit of stigma around the services, or a lot of not really knowing what the services are. And so I love having Lance on to kind of clarify those services for us and just really give us a nice baseline of information, so that way, if and when the time comes, we know where to reach out for that assistance, right? So thank you again, Lance, for your time. I always love having you on, and I'll go ahead and let you take it away.
Thank you, Jenny. Good morning, everyone. Glad to be with you all. Always a pleasure to be a part of anything that Alabama Respite, Lifespan Respite participates in. And I know Jenny does a great job with the education to our caregivers and many of you across our state. I know you're caring for someone you love, obviously, and I know they provide a lot of support. But to Jenny's point, there is a lot of stigma and fear around the word hospice. And I hope today that I can answer your questions, but also provide some education to overcome maybe some misconceptions you even yourself have had. And of course, I had before I started working in hospice. So hopefully we can get right to it. If you have questions, feel free throughout. You can always, I think, Jenny, will you be watching if somebody kind of has a question,
Yes, I can watch the chat.
Okay.
So if there is a question that pops up, I'm more than happy to bring it to your
Absolutely.
attention.
Thank you. And then, of course, we'll have questions at the end as well. So we'll go ahead and get started. Today, we are talking about the difference between hospice versus palliative care. They are two different types of care, but also similar in nature. So our objectives today is to improve knowledge and awareness of palliative care and improve knowledge and awareness of hospice care, as well as identifying services provided by palliative and hospice care, and especially want to discuss the myths and misconceptions about hospice and when to receive hospice care. So just as a way of introduction, there's a lot of research that we can all find out there about hospice and palliative care. But the interesting thing is all the research shows that hospice and palliative care, there's improved symptom control With the disease progression, patients and families report a better quality of life, increased satisfaction with those types of care. But however, both types of care are the most underutilized medical medical services that we have. A lot of people don't know when to utilize it or really know the difference, but also when to ask for hospice or palliative care, when to utilize it along their healthcare journey. But it is the most underutilized care there is. So in a 2016 survey of 800 participants, they were asked questions about their knowledge of hospice and palliative care. 73% of those individuals self-reported that they did not know what the term palliative care meant. 27% noted it provided some type of symptom management to patients, while 19 noted palliative care was applicable at any course of a life-limiting illness. In regards to hospice care, 60% associated it with end-of-life care. 13% mentioned it was comfort care, but only 5.3% identified hospice as providing care to patients and families. You know, a lot of times we'll talk about one of those myths. People think hospice is a place, that you go to. Along with that, among hospitalized individuals, now this is from research from Medicare, Medicaid centers, fewer than 5% are seen by palliative care, and less than half of all individuals who do die in the U.S. only receive hospice care. So less than half of all those who are hospitalized only received hospice care. Over 70% of surveyed individuals self-reported little to no knowledge of palliative care, and 30% of respondents agreed with the myths or untrue statements such as hospice care is only about death and hospice is seen as giving up. And we'll deal with those myths later in our talk. But overall, if you research this on your own, palliative, hospice, all the things, multiple studies have noted that patients and caregivers being asked to consider hospice care are often unaware of just basic information about hospice care and palliative care for that matter. And we're going to discuss those two today because a lot of our healthcare system and hospitals use them interchangeably, but there are different types of medical services that are available to us. So we're going to start with palliative care. The Center to Advance Palliative Care defines palliative care as a specialized medical care for people with serious illnesses. It is focused on providing patients with relief from symptoms, pain, and stress of a serious illness, whatever the diagnosis. And the illness could be a lifelong illness, or it could be an illness that's acute, that happens suddenly. But palliative care is appropriate at any age and any stage in a serious illness and can be provided along with curative treatment. That is the key sentence and phrase and understanding of palliative care, that palliative care can be provided at any age, any stage of a disease, and can be provided along with curative treatment, such as any type of aggressive curative type of treatment, whether it be radiation, chemotherapy, if it's a cancer patient, or it could be someone who has end-stage or kidney disease. They're seeking curative treatment. They're seeking dialysis. They're seeking interventions, surgeries, stents, and, bypasses, all these things that are considered curative treatment. And palliative care can be provided alongside of those things. Even, as I mentioned earlier, something suddenly, I've told my wife, God forbid, if I'm in an automobile accident, something that happened suddenly and injured, send me to UAB. UAB has the most, what I call true palliative care program in the Southeast, in Alabama for sure, and Birmingham area. Because I know I'm going to be experiencing pain and different types of, complications from, the accident. So I want to be treated with palliative care while I'm being, God forbid, again, surgeries, all these interventions that may be needed for my healing. I want palliative care to be alongside of that healing process. So Palliative care is a specialized medical care for people living with illness. It can be provided, like I mentioned, in hospitals, nursing homes, outpatient clinics, or even at home. Palliative care is provided in combination with curative treatment, which is, again, the primary difference between palliative care and hospice. But so it is for the patient and to support the family by the way of providing aggressive symptom or pain management of that illness. It usually has some type of layer of psychosocial and spiritual support, depending on the palliative care services that you choose. Most palliative care services programs do have access to a social worker or a chaplain. But the primary goal is to assist with your goals of care. What are your goals of care? Along your disease, you know, what types of interventions, treatments are available? Do you want palliative care? A whole nother palliative care team, a specialized team coming alongside of you during your illness to help provide support and symptom management along the journey. It is delivered by an interdisciplinary team. Typically, the physician or the nurse practitioner, they are certified in palliative care medicines. It is a special certification as well as hospice. These physicians and nurse practitioners advance their education and certifications in pursuing a palliative and hospice certification to be able to provide these levels of care. The goal is comfort along the way of the treatment process. Again, in some palliative care services, depending on your location, depending on the availability in your area, just like the interdisciplinary team could include a social worker or chaplain. It could also include some bereavement help if your loved one should have passed away while on palliative care. But palliative care in general is affirming life regards of the dying, and regards dying as a normal process of life. Goal again is to seek a quality of life. Whenever you think of hospice and palliative care, it's always about quality of life, not necessarily focused on quantity of days, but quality of days. How do I want my current condition? How do I want my days to look like? And do I want that additional supportive care services, palliative care, alongside of my treatment journey? So an example of a palliative care patient would be someone that's newly diagnosed. It could have been sudden onset illness, or it could be a lifelong chronic illness, but it's newly diagnosed. You are focused on pursuing curative treatments, those aggressive type of treatments that's offered or maybe available. Um, you're pursuing treatment, but unable to, maybe there's not a cure, but you're still pursuing treatment along with your illness. And then living with their illness and no longer receiving treatment targeting their underlying illness. So this would be, again, receiving palliative care at any stage of the disease progression at any age as well. And again, overall, patients and families who have utilized palliative care that have been surveyed, again, feel like they have improved outcomes, better quality of life, better symptom control because someone is specialized education in how to control those symptoms along the disease journey. Obviously, it focused on the spiritual and the psychosocial aspects of the disease progression. So they're going to receive and, verbalize a more satisfaction with their care because we're seeing the person as a whole and all the things that come in that are layers of the disease journey. It's not just the medical, but it's also psychosocial, spiritual, that affects the patient and the caregiver. Also, the benefit of palliative care is that it is known that there are fewer hospitalizations, fewer hospital days, which obviously would be less burden on the caregivers if your loved one is being treated so well and manage their symptoms better at home with palliative care, and they're no longer having to go in and out of the hospital, which creates that extra burden for the caregiver having to go to the hospital and, and advocate for your loved one. So there is the benefit to having palliative care alongside of the disease journey. So what happens and what has happened over the years, I've seen the changes, especially all physicians, most physicians, most hospitals, social workers, whomever you are on the front lines, they have interchanged the word hospice to use the word palliative, because palliative is much more of a easier word to talk about, right? Because if a doctor recommends hospice at the hospital, then a lot of times they get a lot of resistance because of the stigma of hospice. And my loved one's not dying. They get a lot of pushback. So what they've done is over the years they've utilized this word palliative care to kind of make it a little bit easier on the families and the patient to start thinking about having extra support along their journey, because all hospice care is palliative care, because we just said the simple definition of palliative care is symptom and pain management. So all hospice, it's like this umbrella. I think of dementia. Dementia has many types of layers of dementia. There's Alzheimer's dementia, there's Lewy body dementia, there's Parkinson's dementia. So you got this umbrella of dementia with different types of dementia underlying it. And that's the same with palliative care. Palliative care is just this umbrella of services focused on symptom and pain management of an illness. But hospice care is just a little piece of that. And that little piece of that is going to be when a patient is at end stage of their disease progression. So, you think about the last year, whenever someone is, you know, has been assessed and the doctor says, you have end stage heart disease, end stage COPD, or the latter stage of the disease, the life-limiting illness. So that's where hospice care is on the palliative care spectrum. So all hospice care is palliative care, but not all palliative care is hospice care. Hospice is dependent upon the patient's stage of illness, which is end stage or the last stage, and their goals of care. If you're not familiar with the Conversation Project, I would highly encourage you to kind of look at a lot of their resources. They do a lot of research themselves, and they have indicated that 92% of Americans say it's important to discuss their wishes for end-of-life care, but only 32% of families have those conversations. So it's always too early until it's too late to have those conversations, thinking about what my loved one would want, what type of service, what type of care, what are their advanced directives, what are their desires when the disease has progressed and they're more homebound, debilitated, increased symptom burdens. What has my loved one said that they would want, what type of care they would want at end of life? And the Conversation Project has a lot of great tools to get caregivers, families having those discussions. So I would encourage you to kind of research the Conversation Project. They have a lot of great tools out there to how to bring these conversations up in family conversations with your loved one and extended family members.
Lance,
Yes.
there is a question in the chat.
Okay.
Is there a time limit that you can stay on palliative care?
So are we talking about palliative care? So palliative care is really what I call it's really going to palliative care. If you're seeking curative treatment for a disease, then palliative care is going to be intermittent. So it's really going to depend on the palliative care and your insurance. um, how insurance pays for palliative care. I would say it's more intermittent. It's sort of like, you know, going to your cardiologist or going to, your primary care provider. Now, depending on your insurance, many of the insurances today, like United Healthcare, Viva, some majority Humana, many of these insurance have a benefit for palliative care already in the rider, and there's certain criteria that the patients have to meet to be able to access that program with United Healthcare. Of course, if you're, you might want to do a Google search of like palliative care in your area, but if you're in the greater Birmingham area, and you're a UAB patient, again, you have the best access to palliative care. They have outpatient programs. Obviously, they have a lot of our hospitals across the state of Alabama have palliative care teams in the hospital. But typically with palliative care, it's going to be intermittent. Once you kind of get the symptom burden stabilized, then a lot of times you don't need them until later, but it may take 6 months to a year for them to actually get the symptom burden stabilized. But if your pain is controlled, say if it's related to pain, if your pain is controlled, once they get it started and get you on a good regimen, your loved one on a good regimen, palliative care can pull out and then allow the primary care physician or the specialist, cardiologist, oncologist, just keep managing your care at that point, if that makes sense. But with hospice, it's going to be a little bit different. And we're getting to the hospice side of the length of stay of hospice, okay? So let's talk a little bit about the hospice, and maybe that can answer the question of when our loved one's in hospice, how long can you stay on hospice? So hospice, but the Centers of Medicare and Medicaid Services define hospice as a comprehensive holistic program of care and support for terminally ill patients and their families. Hospice care changes the focus from curative care to comfort care for pain relief and symptom management for the patient's illness. So hospice, to me, I always say is the highest medical level of medical home care that you can get, that your insurance pays for with no copays for anything that I'm going to be talking about under hospice, the benefits of hospice in just a minute. It is truly the highest level of home care assistance you can get. But just a little background on hospice. It actually started by a social worker in England in the 1960s, Cicely Saunders at St. Christopher's Hospice. And what they had seen after the 20th century, when we were, if you think about centuries over a century ago, or not too long ago, but a century ago, people were born in their homes and they died in their homes, right? And so doctors came to the home and all those things. But as we had medical advancement and saving life and prolonging life, and a lot more advances in technology and medicine and science, you know, we have this, our healthcare system has this God complex that they can save everybody and heal everyone. And so people were dying in pain and dying without dignity and dying alone in the hospital settings or in a, institutionalized setting. And so Cicely Saunders says, we got to do something better here. So she came up, again, not really a new idea, but going back to the idea of, again, holistic care, focusing on pain and symptom management of a life-limiting illness and making sure patients are dying with dignity at the end of life. So the first hospice in America was in the 1970s in Connecticut. And then in the early 80s, Congress began to study hospice care and really noticed the benefit of people, again, having better quality of life at the end of life, satisfaction with care, symptoms being managed, and a better dying experience. And so they enacted the Medicare hospice benefit, which directs all of our hospice with all of basically our insurances today. All major medical insurance has a hospice benefit. So hospice care is delivered at the end of life when someone has an end stage life-limiting illness. It is, again, care for both the patients and the family. We look at the whole family and provide support for the caregiver and the family as well. It is focused on symptom management. You get a full care team focused on psychosocial and spiritual support. We're assisting with your goals of care. It is delivered by an interdisciplinary team, which we'll look at all of those members in just a minute. Our focus is comfort, aggressive comfort care, symptom management, no longer curative. Bereavement services is a part of hospice care. And again, we're affirming all of life, but also that dying is a normal process. And there's what we believe can be a good death versus a bad death, and that we have our choice of managing our mortality. We can't control the length of our days only, but we can control and have a choice of how we want our days to look like and what type of support we want and how we want our pain and symptoms to be managed. And we seek to improve the quality of life. Hospice affirms life. There's nothing the hospice can do or will do that hastens or postpones death. There's a lot of misconceptions, and a lot of that is around the use of morphine. A lot of people, when they hear the word hospice, they automatically think of morphine. And those are types of comfort medications we give toward the end of life. But, you know, if you think about it, if you and I had something God forbid, something suddenly that happened to us today, whether, we go into the ER, the first thing they're going to give us is morphine for pain and to relax our breathing if we're short of breath. That's where we're going to get. You're going to get morphine unless you're allergic to it and they already have it on your file. It's going to be given to us because it works. It works. But not everyone dies that goes to the ER and gets morphine, right? So again, a stigma that we have developed over the years because we associate, again, hospice with death and with morphine. And, unfortunately, the reason why that we associate hospice with death is because we wait too late to refer to hospice or ask for hospice. Right now, the average length of stay on hospice is 17 days because either the physician has waited too late to refer or the family has waited too late to ask for hospice. And so we are admitting patients to hospice in their last final weeks or few days because of that reason. And so they're going to most likely already be getting the morphine because they're already in distress when they come onto our services. And we want the patient to be comfortable. Whereas actually hospice is available to us much earlier than those last 2 weeks or 2 days. It is a benefit available to us um, because it is an insurance benefit. Most people don't realize I have a hospice benefit under Blue Cross Blue Shield, and it is covered by most insurance plans. And typically, the guideline for hospice is if the disease takes its normal course of action, your best educated guess, do you think the patient will pass away within 6 months or less? And I know that gets a lot of people hung up on that 6 months or less, but no one knows. It's just an educated guess. And so we actually have people who live beyond the 6 month mark and they can stay on hospice. Our insurance gives us the ability to remain on hospice, to be recertified for hospice, to continue to qualify for hospice as long as the hospice can document the decline from the progressive disease. And so we have patients right now on our services who elected their hospice benefit for COPD, congestive heart failure, Parkinson's, dementia, all of these diagnoses, and they've been on our services a year or a little longer. And so it is available to us much earlier than those last, again, 17 days or less. And um, hospice will not cover any cancer-directed therapy. Again, cancer-directed therapy is considered aggressive curative treatment. You know, those types of therapies that are radiation, chemotherapy, um, even the chemotherapy pills that patients may take, any type of infusions, those are curative, life-sustaining, cancer-directed therapies. So hospice cannot be provided alongside of those types of things. There are specific treatments that are possible and part of the care planning process. You know, for an example, someone who may have um, end-stage renal disease and they're having active symptom burdens where they may go to have dialysis and they can't finish the treatment, or they go for dialysis and they end up in the ER because it's dropping their blood pressure, increasing their blood pressure, all of these types of different things that's going on. So typically in general, most hospice would not admit a patient who had end-stage renal disease onto hospice as long as they're going for dialysis. However, depending on the goals of care conversations, we have at Expect Care, we have talked to patients about their goals, and they understand where they are and that they're, they're in system failure, and that the treatments are no longer beneficial to them, but they may want to have a few more treatments to be able to kind of get their affairs in order, to talk to their family, to have a little bit more time to see, their grandson graduate, from college or high school, or a new grandchild being born. And so we're going to Expect Care, our hospice is going to work with that particular patient and looking at any type of specific treatment which would otherwise be considered life-sustaining or curative, and to see if we can help just guide them through those last final treatments and allow them to come on hospice while getting those last few treatments. So what is the benefit of what does it all include? Many of you probably have had an experience with home health or currently have home health in your home right now. And typically with home health is a short-term service focused on rehabilitation the ability to try to get the patient back to where they were before the sudden illness happened or the fall um, that may have taken place. So you're going to have typically what that looks like is you have a nurse once a week, maybe a physical therapist coming out twice a week, or occupational therapist. Depending on your insurance, depending on your home health provider, it may include a bather, but typically it doesn't on the home health side. But that's your care team for home health. And again, it's short term. It's going to last maybe 6 weeks. It could be extended depending on the progression of the patient. If the patient can tolerate the physical therapy, but at the point of time where they're no longer meeting their goals in therapy, or they've already maximized their therapy goals, then home health has to pull out, and then you have no medical support. So how hospice is different, and the benefit of hospice is if you qualify for hospice with a life-limiting illness, progressive illness, then you get a full team available to you automatically, immediately on admission. We become your new medical 911. There's no need to go to the ER or go back to your doctors, because we bring medical care to you in your home or the place you call home. Expect care. We have 3 medical directors who manages our patients' care at home, but your team includes automatically a nurse who comes out again routinely twice a week. Automatically, you receive a bather that typically average comes out 2 or 3 times a week. You'll get a social worker and chaplain for additional support. And as our patients' needs change, our visits change. So though our routine may be coming out 2 or 3 times a week, we can come out daily. If our patient needs us to come out daily, they're having an increased symptom burden. If our nurse was there this morning and needed to come back this afternoon, we're going to come back out. And and to that point, we have nurses on call after hours and weekend. Hospice do. We're available 24/7. So if your loved one woke up in the middle of the night at 2 o'clock in the morning and they were short of breath or having some type of change, you just call our nurse. We come out in the middle of the night and we can get care started, changing medications, different type of medical equipment, whatever you need. We can do mobile home x-rays. God forbid if our patient falls. Well, there's just a lot of things that we can do in the home, again, to manage their care. So you get a full care team supporting you. We have volunteers in our area that help support giving our caregivers a short respite break. So they're non-medical volunteers, and they also visit our patients and just provide friendly socialization. Bereavement services are provided to helping with our grief support. But our care is provided wherever the place the patient called home, whether it's a residential home, um, nursing home, assisted living. We provide wherever the patient is. We actually, when you elect your hospice benefit, do you not have a full care? Not only do you have a full care team available to you immediately, but we start supplementing some of the medications. We start paying for some of the medications typically related to pain and symptom management, sleep, anxiety, constipation. Those are things we normally pay for. We also start providing on admission and supplementing any type of medical equipment that our patient needs for their care and for the caregiver safety of caring for the patient. A lot of times if you're not on hospice, you're having to, there's different types of qualification that the insurance requires to be able to get a hospital bed or to be able to get oxygen. And all of that red tape is foregone once you elect your hospice benefit. We're able to do that. In the same way with pain medications, so when you elect your hospice benefit, typically if you're not on hospice and you're receiving any type of pain medications, the law says you really have to see a physician every 30 days. And most physicians require that, obviously, to come into their office. They're not coming to the home. So that becomes a difficult task when, again, someone is more bedbound and they're advancing in their disease. And it's really hard and difficult to get them to the doctors, right? In the hospital, um, to the pain clinic or wherever. So we can provide all of that immediately on the spot at home. And then hospice also starts supplementing personal care supplies like, your chucks, your incontinence briefs, any of those types of things, wound care supplies. We start providing and supplementing those as well. And it's all covered under the hospice benefit, and there's no copays for any of these things. But some of the things that's not included is hospice does not pay for room and board in a nursing home at a residential facility for long-term placement. We do not pay for emergency room or inpatient facility care or ambulance transportation unless for some reason we've had to order that. We do not pay for prescription drugs or supplies that are related to treat an illness or condition unrelated to the hospice diagnosis. For example, that would be hospice typically does not pay for diabetic medications because that's not part of the terminal illness that we're providing care for. But our social worker can help find resources if there's an income barrier to paying for insulin. Our social worker can help with those resources. And of course, hospice does not pay for any type of curative treatment, uh, as we discussed. There are 4 levels of care of hospice, and those are what we typically think is routine hospice care, where the nurses come in twice a week, CNA, 2 or 3 times a week. But there is the one of the differentiators of hospice, other than any other healthcare, is respite care. We are able to provide to our caregivers a 5-night, 6-day respite break periodically. And typically, what that looks like is we relocate our patient from their home into a contracted uh, nursing skilled facility that we have contracts with. And hospice pays for those days, those 5 nights, 6 days for the room and board to give the caregiver a break. And a lot of times caregivers utilize this to, maybe go on vacation with their children or extended family. Sometimes they have to use it for their own medical needs. Others just utilize it just to truly get a break. But it is a benefit available only hospice can provide. And thankfully, we have Alabama Respite that supports and helps provide respite in the home and things of other resources. But from a medical healthcare insurance benefit, currently hospice is the only thing that provides respite. We are able to provide hospice in a general inpatient uh, type setting and continuous care. So what that looks like is if our patients, when they're in their home on routine home care, if our nurses team is there and our patients, we cannot get our patients' symptoms under control with oral medications and the things we can do in the home, then we can implement a higher level care, which is called continuous comfort care, where our nurse can stay in the home kind of indefinitely, whether it take hours on end to get that symptom under control, or we can go to the highest level of hospice care, which is called general inpatient care, which in our area, we have contracts with hospitals. Our preferred contract is UAB Palliative Care Unit at UAB Hospital. We relocate our patient from home to that type of setting, again, to have 24/7 management of that symptom, to get that symptom burden under control. And once we do, we get them back home to routine home care. But we have these levels of care available to us, again, to really focus on the patient's quality of life, managing those symptoms, and keeping them out of the ER in the hospital for further treatment. So in that same study we talked about earlier, they were asked with the definition of palliative care and asked, would you recommend this type of care to loved one? and 62.9% responded very lightly, 28% responded somewhat lightly, 8.6 responded not too likely, not at all, and 0.5 responded do not know yet. But as you can see, once we understand palliative care and hospice care, most people are most likely or somewhat likely to utilize it and want it to be part of their care and the conversations and the goals of care. So as we think about some of the myths and misconceptions, one of the things I've heard over the years is hospice is a place to receive care. Well, as we talked about it earlier, hospice is a type of medical care, specialized care that is provided in the place that the patient calls home. So wherever the home is, again, we do provide care in nursing homes, assisted livings, independent livings, and of course, residential homes as well. Hospice is only people for people with cancer is another myth. As I mentioned earlier, we have a lot of patients still on our services with non-cancer diagnoses with end-stage heart disease, COPD, end-stage Parkinson's, end-stage dementia, all the non-cancerous types of diagnoses. So it is not just for cancer diagnoses. Hospice is only for older people. Well, most of our patients are 65 and older, but the fact is hospice can be provided to anyone at any age, and it's covered by most insurances. And in fact, almost 20% of hospice patients currently are under the age of 65. Hospice can only help when family members are available to provide care. Now, we do get ourselves see this a lot, and this is a hospice to hospice specific business decision, if you will. There are some hospices that will not admit a patient if there's not an identified caregiver in the home. And so, however, that is not a Medicare or insurance requirement, but we recognize at Expect Care that family members are still trying to work a lot of times, and this may be a new onset, a lot of new changes. And we try to, yes, there has to be an emergency contact, a caregiver available that we can call, but there has to be a plan in place that when the patient can no longer say, um, call 911 in case of a fire or an intruder or, natural disaster, then we're going to have to make provisions, help, and our social worker helps to find maybe additional caregivers, resources, and support, or we can help with long-term placement and transition to a skilled nursing facility. But hospice, we do not take place of a caregiver. So if a patient is needing more assistance with toileting and changing and bathe, those types of needs, then we expect that there be either a family member or paid caregiver helping change the patient when the hospice is not in the home. We've already talked about this, that a little bit. Choosing hospice care means you are giving up. Well, while being on hospice means patients have a prognosis of 6 months or less if the disease takes its normal course of action, we don't believe it's giving up. We believe that you're redefining hope. We're not hoping for a cure because we understand that's not available to me right now, but we hope that we can have a better quality of life and we can have our pain and symptom managed and remain at home and in place and not in and out of the hospital and you know have the full support. Hospice care can lower the stress of caregiving and the anxiety of providing care as we provide care and available 24/7. So it's more about you having control over your final moments, over your symptoms, and managing those last few days and months. Another myth is once you are under hospice care, you cannot leave. Well, we always, we're always patient advocates. So it's always about the patient and or the power of attorney, the family member's goals of care. You know, if your goals change and you want to come off hospice care, you change your mind, that is your right. That is your patient right. And so we do have that happen from time to time. Maybe family members decide, oh, I do want to go back and try some more aggressive rehabilitation or aggressive cancer therapy care. And that is your right. And if your goals change later down the road, you can elect hospice again and get back up on hospice service if your loved one qualifies. So you have complete control over what you do. Another misconception about hospice is that you must sign a do not resuscitate to enter hospice care. And that the reason why this has become an issue is, again, this is a business to business decision from a hospice. Some hospices require the patient or family to sign a do not resuscitate on admission to receive hospice care. That is not a Medicare or Medicaid requirement, insurance requirement. But at Expect Care, we understand that having those conversations are very delicate and sensitive, and our patient and families may need more time, and we might need more education that our social worker and our nurse provides along the journey. So that is not a requirement for Expect Care, but it is something to consider, especially if your loved one says, they do not want life support or, be on a ventilator and all these things, these terminologies, these conversations we have. If they've made their wishes known, I just want to be home, I just want to be left alone, and I want to be comfortable, then, you know, might want to consider signing a DNR so that, they can die with dignity. Hospice care makes little difference to patients. Well, actually, a study carried out in 2010, and we've had a few others since, demonstrated that patients who choose hospice care actually live longer, 3 months longer, than those who opt for standard curative care. And they reported a better quality of life. So, what interesting that happens is if you elect your hospice, then we're aggressively managing those symptoms at home, and you know, we're keeping our patients at home in a more, what I'd say, better controlled environment, infection free, in the sense that a lot of times what happens when someone has compromised situation at the end of life and they're in and out of the hospital and rehab and all of these facilities, they're unfortunately, they may be susceptible to sepsis, to pneumonia, to all of these diseases, to COVID, all of these things that are rampant at the hospital when they're already compromised. So, in that sense, it makes sense that patients would live longer and have a better quality of life at home. Hospice care ends at the time of death. As we mentioned earlier, part of the interdisciplinary team is bereavement services. So, we're there to support the family and the patient uh, prior to death, but we also continue to support the caregivers following death as well. Every hospice has a grief support services available to family members, and we follow their family members at minimum up to 12 months, 13 months, and sometimes beyond if the bereaved caregiver family member is having difficulty adjusting, with grief reconciliation. And so we're going to provide that additional support. And we do that in multiple ways at Expect Care. But it is part of, again, the hospice care. You know, for those patients, as we said earlier, that most patients, die without hospice. Less than half patients who are dying, we and they're dying in the hospital or nursing home, without hospice. I always say, who's following up with those families after that loved one has passed? Does the hospital follow up? Does the nursing homes, these, facilities follow up? And of course, we know the answer is no, because they do not have bereavement services as part of their level of care typically. And so it's good to have that extra support and hospice being provided to the bereaved families. So maybe all of this, you have a question is, when do you ask for hospice? When do you refer to hospice? If just overall, again, when you know your loved one is toward the latter stage or end stage disease, and you see a decline in overall physical and mental status of your loved one over time, you're noticing weight loss. I mean, you're trying everything with, the shakes and, glucernas and all of these insures, and they're just kind of eating less, and you're seeing the weight loss. Their clothes are fitting loosely, or there's frequent hospitalizations or ER visits because you just have recurring symptoms every few months, frequent infections every few months, pneumonias, bronchitis, UTIs, sepsis, frequent falls, uh, you know, history of cardiac arrest or invasive treatments like bypass surgeries and stent placements. Um, Loved one is having frequent chest pain at rest or with activity, shortness of breath at rest or with activity. Maybe they're needing more oxygen, started wearing it at night, but are needing it more throughout the day with just a little activity, as well as maybe they're requiring more assistance with their bathing, their eating, walking, toileting. You just kind of seen maybe they were walking with a walker a few months ago. Now they're mainly in the wheelchair to the bed. Just this overall progression that you're noticing that the disease taking its course. Those are maybe times to start having a family conversation with your loved one, or a conversation with your doctor, conversation with a local hospice. Does my loved one qualify? And these are some of the sources we've cited. So, as we finishing up here, I know that was a lot of information um, about palliative care and hospice care, but I do want to take, if we have a few minutes, Jenny, if you have any additional questions or if you need assistance, even after this meeting today, this is my contact information. You can call me, my cell, anytime, 24/7. Email me. Again, we serve Jefferson, Shelby, Chilton, Walker, Coleman, and St. Clair counties. Those are the areas I serve and work in. But I did have a caregiver, I'm not sure if she's on the call, from Florence. That's part of the Alabama Respite Caregiver Education Support Group. She called me a couple months ago, and I was glad to help her answer some of her questions. So you feel free to call me from anywhere in the state of Alabama, and I'll kind of give you some guidance of how to contact, your local palliative or hospice care services. But I just want to be a resource. That's what I enjoy doing, is helping, being a resource to caregivers. Any other questions?